Hello everyone. Welcome to the Stanford Chronic Pain Self-Management Program International Perspectives webinar. We're glad you're here today. My name is Tanya Hyde and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is co-sponsored by CIRPD and Pain BC in collaboration with the Canadian Pain Coalition. It's also made possible through the support of the Community Gaming Grants program through the BC government. As I mentioned, my name is Tanya and I'll be moderating the webinar and handling the Q&A session today. And our presenters are Dr. Sandra Lefort and Nikolai Holm-Faber. Dr. Lefort developed the Chronic Pain Self-Management Program in 1996 as part of her work, her PhD work at McGill University. And the CPSMP is now part of the suite of self-management programs offered through the Patient Education Research Center at Stanford University. And Nikolai Holm-Faber is a chief consultant with the Danish Committee for Health Education in Copenhagen, Denmark. He was trained in the CPSMP in Toronto in 2010 and then brought the program back to Denmark. And I will go ahead and hand it over to you, Sandra.
Thank you very much, Tanya, and thank you everyone for joining us this afternoon. At least it's afternoon for me. It may be heaven knows what time it is for all of you. Anyhow, let's just get started here. So our objectives for this presentation are, first of all, I'm going to present a brief overview of self-management and why self-management is so important for chronic conditions, including chronic pain. I'm going to briefly go over the theory, process, and content of the Chronic Pain Self-Management Program, and then discuss the dissemination and the research that's been done on the CPSMP in North America and in Denmark. And Nikolai will be taking over the last part of the presentation, telling us about the Danish experience. So first of all, and before I get started, I'm just going to say that I'm going to go through these slides fairly quickly, but they will be available for you in a week's time, as Tanya mentioned. So first of all, what is self-management? And there's been a lot of work done on this concept over the last couple of decades. But Barlow has a very good definition, I think. It's the individual's ability to manage the symptoms, treatment, physical and social consequences and lifestyle changes that are inherent in living with any chronic condition. So it's the ability to manage people's overall lives, really. And the tasks in all chronic conditions, while different types of chronic diseases or different conditions, of course, have their own specific issues, really, all chronic conditions need certain types of day-to-day management. And this includes medical management, managing the medical treatment, managing the symptoms inherent in chronic conditions, often relating to pain, difficult emotions, depression, fatigue issues, sleep problems, memory problems, whatever those symptoms are. And then managing the physical, emotional, and social consequences that arise day to day with managing this chronic condition. And then, of course, often they involve being able to manage lifestyle and role changes that happen as a result of the chronic condition. So these are the kinds of self-management day-to-day issues that anyone with a chronic condition has to face. And what we know is that there's been a lot of interest in the concept of self-management as chronic diseases start to be much more common in populations all over the world, as opposed to more acute conditions that often were prevalent prior to the 1950s. So briefly, the history of self-management. It's a term that was first coined by Dr. Thomas Greer in the 1960s. He was a pediatrician in Denver, and he started to notice that children who were more actively involved in managing their own little condition, whatever that was, tended to be better able to, they just got better. They were living better lives. And he quoted this term, self-management. It emerged as a major research priority in the 1980s, following prevalent studies of chronic illness, of course, that was arising in the 1960s and 70s. And the other thing that was happening was that there were major critiques of standard patient education. Often, patient education, of course, was given to people who had different types of chronic diseases, but they tended to be more factual information that was being given to people. They were too narrow in scope. There was very little active involvement of the person who had the chronic condition in the education process, and it didn't address the multiple issues that were related to long-term conditions. So that's the history of how the whole concept of self-management and self-management education started to evolve. So what is self-management education? So these are programs that are based on adult learning principles that provide patients or clients with the core skills that are needed to live an active and meaningful life. So it goes much, much further than just giving people information about the medical management or the information about their disease. It's how are they going to live a better, more active, meaningful life. And I think most importantly, the goal of self-management education is to maintain a wellness focus in the foreground, even in the midst of a chronic condition, to improve quality of life. In other words, while the person may have a disease, there's lots about them that's still healthy and well, and that's what they need to understand, that people can maximize their wellness. So that's what self-management education ideally should be trying to target. Now, Dr. Kate Lorig at the Patient Education Research Center at Stanford has done a lot of work in the development of self-management education, and has the Stanford programs, the whole suite of the Stanford programs, are really trying to, I guess, target 5 core self-management skills in the patient education programs that they have developed. And those key skills are problem solving, decision making, how people can use resources to help them with their problem solving and decision making, how they can build better partnerships with their healthcare providers, and how they can take action so that they can start to make change in their lives. So these are the 5 core self-management skills that are really integrated into the way the Stanford model has developed over the years. Now, just to let you know a little bit about the Stanford self-management programs, the first program was developed very early, in the late 1970s. Dr. Lorig got some federal funds to develop a program for people with arthritis, since they had found that arthritis was a very prevalent disease that was occurring in the older population. And they knew that this was going to have a big impact on the healthcare system. So she started developing an arthritis-only program initially. And then as they started to get more interested in other types of chronic diseases, they started to realize that they could integrate a lot of the same types of skill development into broader kinds of programs. So they developed the Chronic Diseases Self-Management Program, which really targets people who have respiratory problems, heart disease, hypertension, diabetes, and arthritis. They also have developed a diabetes-only program. There's a program for HIV/AIDS. And then I came along in the mid-1990s looking for a patient education program for people who had chronic non-cancer pain. And then that's been further extended by people in Kingston, Ontario, where they've added a structured exercise program component to it called the YPEP program. And there's subsequently been a program for chronic angina pain, and there's another new program called Cancer, Thriving, and Surviving. So these programs continue to be developed and updated and disseminated. Now, the theoretical base for all the Stanford programs are based on 3 major concepts. The first is self-efficacy theory, developed by Dr. Albert Bandura, who was a social psychologist at Stanford. And really, the idea here is that it's more than, people have to know more than what to do. They have to believe that they can be successful and that they can organize and integrate cognitive, social, and behavioral skills to achieve control over everyday circumstances. In other words, people have to have the skills, but they also have to have the belief in their own ability to control their everyday life. So part of the way Stanford has built their programs is to make sure that there's this built-in component where people start achieving success, and so they can start to see that they can make a difference. The other thing, of course, that's based on this as well is this idea of an empowerment philosophy, that you really have to empower people, give them the skills, and give them their self-confidence to be able to make change. And, of course, it's based on a community-based health education model. In other words, that health education can be provided in the community in many different locations, and the model has further developed into using peers, not healthcare providers or health professionals, to deliver the programs, but peers, people who have the chronic disease or condition themselves, can be trained to be the facilitators for these programs. So just as an example of how self-efficacy or self-confidence building is integrated into the Stanford programs, they do this by providing skills mastery, an opportunity to practice the skills in a supportive environment, by providing role modeling in the program, by providing opportunities for people to reframe their symptoms so that they can look at how their belief system impacts their ability to manage their condition. And also there's gentle persuasion, gentle support and encouragement from peers, family, and friends, and so on. So skills mastery, modeling, reinterpretation of symptoms, and social persuasion are the key components that Dr. Bandura said would enhance self-efficacy. And these components have been integrated into the Stanford model. And they're integrated by the processes that are in the programs. And that includes some information sharing, but it isn't jam-packed with health information. It's more small bits of information, lots of time for self-reflection and sharing of feelings. There are small quizzes that address common misbeliefs. There's lots of opportunity for brainstorming. One of the key components of all the programs is setting action plans, where they learn the process of setting short-term goals. There's opportunity for feedback on how they're doing with their goals, group problem solving and decision making, and there's telephone support midweek. So all these processes that are integrated into the Stanford model are there to try to enhance confidence building. So just to go to the chronic pain self-management program, it is a standardized program, and what that means is that there is a leader's manual, and that the manual must be followed as written, so that all the delivery of the program is completely standardized, which is why it can be delivered by peers. It's community delivered, as I mentioned. We normally think of about 10 to 15 people in a group as being optimal. It's 2.5 hours a week for 6 weeks. It's an adaptation of the chronic diseases self-management program. It's about 40 to 45% pain specific, and the rest of it is very much the same as the chronic diseases program. It's a train-the-trainer model of dissemination. As I mentioned, the leaders of the program can be either peers, people who have the chronic condition themselves, chronic pain, or healthcare providers. And very often we found that, often there's one peer and one healthcare provider in different organizations that deliver the programs. Excuse me. And there is a pain workbook and exercise audio CD that comes with the program. And just to let you know that, in fact, a new version of the pain workbook is going to be coming out late in early spring, and it'll be called Living a Healthy Life with Chronic Pain, and that'll be available soon. And the program is also being updated, and that'll be available in the early spring as well. So this is just to give you an idea of the curriculum, if you want to call it that, of the program. So for example, if you look on the top, you see that it's divided into 6 weeks, and that on the left-hand side you have the content. the program activities that are discussed over the 6 weeks. And you'll see that in week 1, for example, we discuss what is self-management, debunking myths, what's chronic pain, making an action plan. And if you look down over the list, you can see that certain things are done almost every week. So making an action plan is something that people do every week. Getting feedback and problem solving about the action plan that they did the week before is done from week 2 onwards. We talk about physical activity every week starting at week 2, and we actually do the Moving Easy program in the class. It's about a 12-minute program, and so people start moving very gently so that they can start to see that they can use relaxation techniques, they can use their mind, and they can start moving their body in a way perhaps that is new for them, and get them started thinking about the importance of physical activity, and so on. So that's just to give you an idea of the way the program is structured. And we often talk about the idea of a pain self-management toolbox. So remember I said that people need the skills or the tools so that they can manage their pain problem day to day, and they also need the self-confidence building. But the tools that they learn in the program are things around physical activity and exercise, managing fatigue, pacing and planning, relaxation and better breathing, how to manage their medications, working with healthcare professionals, problem solving, using your mind, healthy eating, communication, understanding emotion, and finding resources. So we talk about this idea that they have a toolbox at the end of this program. So that's the quick overview of the Stanford program and then the chronic pain self-management program. I'm just going to move now to the research that's been done on the program. And the first was a randomized controlled trial with 110 people who were randomized to either receiving the treatment or into a waitlist control. And the people who received the treatment came for the 6-week program, and then 6 weeks later they did outcome measures. And the people who participated in this randomized trial, the characteristics of these people were as follows. 73% of them were female. Only 38% of them were working. So many of them were unemployed due to their pain. They had pain for almost 7 years. Their age was around 40 years old. 68% of them had either back or neck pain. 80% of them were taking medications for pain, and 62% of them had visited a physician or specialist within the last 30 days, which just indicates that they're very high users of healthcare services. So what we found in the people who participated in the 6-week education program, that they had 9% to 47% improvement in the treatment group on a variety of measures: pain, disability, dependency on others, self-efficacy and resourcefulness, social and physical functioning, mental health, and life satisfaction. And these were all statistically significant. These results were comparable to results that had been shown in the arthritis self-management program and the chronic diseases self-management program, as well as other chronic pain programs reported in the literature that were around 20 to 25 hours in length. And the results supported self-efficacy theory. In other words, that confidence building and increased problem solving lead to better outcomes. We also did a qualitative component to the study. We asked people what they felt they had learned and asked them to comment on their experience. And what they said was that having their voices heard was very important, that often they felt alone. Knowing that they're not alone was very important. Sharing with others who understand. They talked about being in a safe environment. In other words, that a lot of people who have chronic pain feel that they're judged in some way and that it's not safe to talk about the issues that they're facing. And they also talked about that they started to realize they had to take ownership of their pain. There was no magic bullet. If they didn't deal with it every day, it was going to get the better of them. So that sort of just reinforced, I guess, the outcomes of the study. In the early 2000s, we did another study, an effectiveness trial, where we looked at 207 people in 6 rural and urban Canadian sites. The facilitators were community-based nurses and allied healthcare providers. And we looked at measures at baseline at 3 months and at 12 months. And what we found was that, of course, this was now in the real world. An effectiveness trial means that it's done in the real world as opposed to the best of all possible circumstances. And so these were community health nurses who had their own workloads, and that this was, they were facilitating the chronic pain self-management program as an additional service that they were providing to their organization. What we found was that people who did the 6-week CPSMP program had statistically significant improvement in the mental health composite score of the SF-36. So they had improved vitality, social and emotional functioning, and improved mental health. And they also had improved scores on resourcefulness and self-efficacy. And there were positive trends to improvement in disability, psychosocial adjustment to illness, and improvements in life satisfaction. And these results were maintained for a subset of participants. We only followed a subset of people for 12 months, and they maintained these improvements. So again, we did a qualitative component, and they reiterated much of what the others had said in the first study, that learning from others, helping others, was very important. They felt that they actually had information that could help other people, and it made them feel better about themselves. They felt validated. They thought that they were coming to terms with the fact that they had this chronic pain problem and that they had to deal with it. They had increased levels of self-esteem, that they had improved their knowledge and their self-knowledge, and that they had more hope and direction, and that they were learning to manage. So since 2008, the chronic pain self-management program has been disseminated in 5 Canadian provinces, in 19 states in the U.S. It's being delivered in Australia, New Zealand, South Africa, the UK, and in Denmark. And so now, with no further ado, I'm going to hand this over to Nikolai, who can tell us about the Danish experience with the program.
Hello, everybody. I hope that I'm getting through. My name is Nikolai Faber, and as Tanya said in the introduction, I've been working with the pain program from Canada since 2010. I'm a certified team trainer in all the Stanford programs, and a part of the organization called the Danish Committee for Certification, which is a Danish office that runs the Stanford program. This is my agenda on this slide, and I'll try to give you a short insight to why we decided to go to the CPSMP program in Denmark, and what challenges and information about the dissemination of CPSMP and the result of our studies in Denmark. And in the end, I'll try to give you some perspectives about what you can do with a pain program in a country like Denmark. So I've clicked in a small map of Denmark, and we have 5.2 million inhabitants, and 30% have a long-term condition. That means that approximately 1.7 million people are living with a long-term condition in Denmark, and more than 50% of them have a pain issue as part of it. The red dots on the map shows the venues where we are delivering the pain workshop at the moment. In Denmark, we have 98 municipalities, so the venues of the workshop are the municipalities, and we are helping them with the quality assurance and the training of peers to deliver the programs. That means that we're really trying to work with the train-the-trainer idea that Sandra Lepore presented earlier. The Danish Committee for Health Education is a non-profit private organization working closely with the Danish National Board of Health. Because of this link to the National Board of Health, we do no research ourselves. So we have a Danish university that's been doing all our research in the self-management programs and in the training program as well. I'll get back to the study. The reason why we decided to go with the pain program, well, there are different arguments. First of all, we did a quite successful implementation of the chronic disease management program, the mother workshops from Stanford. That means that we had up to 80 of the 98 municipalities running CPSMP workshops throughout the years 2006 to 2009. But when the participants presented themselves, more than 50% said that they had a pain problem as part of their long-term condition. And that was one of the arguments for looking at pain programs worldwide. The second argument was that we did an infrastructural change in Denmark, which meant that the responsibility of delivering service to people with chronic pain stretched from the regions to the municipalities. And they had no experience in dealing with the pain problem. So the National Board of Health identified this gap of treatment, and thereby they decided to ask us to look at the CPSMP pain program. At the same time, in the Danish community of the healthcare systems, we needed to introduce new methods and evidence-based programs in Denmark. And I will not go into the whole argument about evidence-based, but just remind you about the explanation that Sandra Lepore did earlier. Getting to the randomized control trial of the CPSMP in Denmark, first I'll just give you the perspective outside the whole study, which means that this is, in my point of view, a real-time study of the CPSMP in a train-the-trainer manner. The reason I'm saying this is that the study we've been doing in Denmark, the data has been collected from 42 different venues. So we've had 80 peers delivering workshops and in that way creating data for the study. So I have not delivered any workshops. I've been training the leaders, the peers that have been delivering workshops. This means that the two workshops that was included in the study from each municipality, the workshop they delivered was the first two workshops after being trained. So the leaders had no experience in delivering the program when we collected the data. Next, the municipalities had no experience in dealing with the chronic pain patients as well. So the recruitment of people to the study was, well, to say it was a difficult task for the municipalities. We helped them as much as we could, and the perspective from the researchers was that we shouldn't have the pain patients. The hardest problems, but maybe some were less problems. But in the end, we ended up having a group of very severely affected patients with chronic pain. The study was conducted as a controlled trial, as I said, and sorry. And as you know, when you are very close to a patient and you randomize them to the control group, sometimes it's very difficult, especially if there's been no service for this patient before this workshop. So another problem about the whole study was that sometimes the municipality cheated, and even though they were supposed to have a waiting list control group, they offered the control group participants to be at the Stanford workshop with CPSMP. So, as you can hear, trying to simulate and do a randomized control trial at the same time, which is explained in funding, that we only got funding for 3 years, have created some difficulties doing this study. As you can see on this slide, we've been collecting data before randomization, immediately after, and 4 months after. And at the moment, we are analyzing, the university are analyzing the 18-month follow-up in qualitative studies. If I refer back to the studies done by Professor Lefort, we've been looking at some of the same parameters, and here I just mentioned the self-reported pain, functional limitation, pain catastrophizing, anxiety, and depression. Immediately after the intervention, we had some quite positive and significant effects on functional limitation, pain catastrophizing, and depression. And in our view, seen from the committee's side, the Danish Committee for Rehabilitation, these are excellent results because reducing functional limitation, reducing pain catastrophizing, and depression means that you can function better and have a higher wellness factor, as Professor Lorik says in the slide of control. So these are very important effects. After 4 months, we found positive effects on almost all parameters as well. We had a response rate of 93, and we're very proud. The only problem was that the control group was moved somewhat ahead at the same time. So even though we can see that after 4 months, still on all the parameters we have positive effects, it's only essentially on reduction of depression and reduction on anxiety that we have significant effect after 4 months. Of course, we're looking to see the 18-month follow-up, but the researchers have an immediate conclusion saying that the CPSMP is cost-effective intervention immediately after, when you measure immediately after, which is positive. When you compare to other kind of services to the chronic patient, this is actually very positive results. After 4 months, we can still see effects and reduction of depression and anxiety, which are parameters, or at least effects, I would say, that creates the possibility of having a better life anyway. So positive results. We would have loved to have had more significant effects at this time, but as I started off by saying, especially the 42 different venues and the 80 peers delivering the program, this for the first time very important arguments to consider when we look at the effects. So my conclusion and the conclusion of the National Board of Health in Denmark is that the CPSMP program is a very interesting program to continue running in Denmark. In Denmark at the moment, we have a low rate of unemployment, but a very high rate of unemployment for people with chronic pain. So when we look at the people being away the longest time from a job situation, 80% of them are dealing with a pain situation. So at the moment, with the CPSMP program, it's closely tied to the job centers in Denmark that trying to help unemployed getting back to work, because that's functional limitation you get when you have a chronic pain situation. It's closely linked to unemployment. Actually, as the board said earlier, also about the data from Canada. At the same time, even though you have small effects measurements in your RCT files, if you look at the broader picture in Denmark, what we're doing now is trying, well, in Danish we say that we're collecting the easy apples to pick. That means that easing the pressure on the regional pain treatment centers, because instead of having chronic pain patients living a life getting worse off every day with their chronic pain, we are actually delivering something that will help some of them. So the amount of people ending up having a very severe pain problem and needing very severe treatment as well is less. So, so at the moment in Denmark, the CPSMP is a well-implemented program. Around 60 municipalities are paying each year to deliver the workshops, and in that way, giving us funds to quality assure the program for the future as well. Next to that, we identified through the study that 40% of the participants had symptoms of severe depression as well. So this was an argument for trying another program facing the problem of mental health and long-term conditions. So in different ways, working with the CPSMP has been an experience of very positive response about the program itself, but at the same time giving us arguments to create and deliver other self-management programs for people which are clearly in need of having some kind of service and support from the society. So yeah, that was my presentation. Thank you very much.
Great. Thank you very much, both Nikolai and Sandra. We have gotten a few questions. One of them was, do you have outcome data of the enrollment to these programs as to whether it's a personal decision of the patient versus if they are requested to join the program? And this tying into the idea of motivation and beliefs being important in outcomes for people who join.
This is a question for me.
Probably either. I think the person presenting it, typed it in when Sandra was speaking, though.
I'm not sure if she means people who were recruited into the studies or just generally all the people who take the program, but I can tell you that the way the Stanford, so the chronic pain self-management program is a Stanford program, and the way that these programs are organized is that individual health authorities or health organizations get a license from the Patient Education Research Center, and they set their own parameters for, in a way, the kinds of criteria that they use for people to come into this to take part in the study. So depending on the organization, some people might be referred to the program by their healthcare provider. Other people might just hear about it in the community. For example, in Ontario, a lot of the different healthcare authorities have it as an ongoing offering in their community health organizations, and so people find out about it, and then they register and take the program. So it really depends, I guess, on the health authority. Now, in Denmark, I don't know, Nikolai, you were saying that the CPSMP is somewhat aligned to unemployment agencies, and I don't know if people are mandated to go to the program or if it's a personal choice.
Exactly, and linking up with the unemployment system has been the biggest challenge we are facing, because until now, last year, the whole issue of attending this program on a voluntary basis was not that difficult. It made sense when we were only talking to the health department of the municipality. But entering the world of unemployment and demands and all these kind of things in the job centers, we are facing the challenge and are testing it. We do questionnaires after each workshop, and one of the questions is, did you enter voluntarily? And we can see from our data that the recruitment officers sitting at the job centers have some magic stick or something that they can get people to attend the program on a voluntary, not voluntary basis. And the not voluntary basis shows throughout those 6 weeks, because when you have the fierce feeling with participants that are not motivated to work with themselves. So what we do is, with this perspective, is that we actually train all the recruitment officers in the job center in how to present this offer, and we train them to see why they can't talk people first. So that was one part of mine. The other part is that the municipalities have different angles to recruitment, and we've tried doing some quality studies in the recruitment channels, what works and what does not work. And at the moment, a good combination of the local newspaper and a good website and the possibility of meeting, calling an recruitment officer at the municipality level is the main channel. We're doing, and we're talking 80% of the participants nationwide. But at the moment, we're actually doing a study, also quality study, where we are interviewing practitioners, general practitioners, GPs, to find out what we need to do to get them to start not recruiting, but referring or just informing patients about the possibility of participating in a self-management program. But this is, I think, worldwide a great challenge to get doctors to refer. But we are fighting to have a voluntary basis overall.
All right. And then two somewhat related questions, one for Sandra and one for Nikolai. Sandra, someone asked if there are particular program options for couples, since chronic pain can affect the relationships around the patient, as particularly a spouse. But then also, Nikolai, there was another person asking the same type of question, but about employers. Like if the employer requested to join the person or to take the course as well, to understand if there's options around those.
I'll start with the couples question. The Stanford, all the Stanford programs, the person who has the chronic condition, in this case chronic pain, can bring a supportive person with them. And that can be a family member, it can be a friend, it could be an employer. So it's open to the person with the chronic pain and a support person that they might want to bring with them. So that's always an option. Now, there's no couples type of activity per se, but there is an activity in the program related to communication, how to communicate with your family. And throughout the program and the program materials, the book and so on, there's a lot of mention about how chronic pain affects more than just the person themselves, but affects all those around them. And that there's I guess people are encouraged to talk about the issues and the ways they're learning to cope with chronic pain with their families and so on. So there's certainly that opportunity provided in the program. How about you, Nikolai?
Well, first of all, I would say that I can answer with the same answer as Sandra before, that the person who would like to participate in a workshop has quite free hands of inviting, supporting persons. In Denmark, we don't see people bringing more than one, but they're very welcome with significant others. About the employer, well, once I've participated in a speech of Dr. Kate Loic, where healthcare professionals were asking a lot of questions about who should attend these programs and who should not attend these programs. and she answered all the questions with ask the patient. So when I discuss recruitment challenges, I always say to the municipality, well, ask the patient. So if I would have one participant saying that he would bring his employer and that makes sense for him in the situation, I would measure that quite significant in the patient setting.
Very good. That makes sense. That makes a lot of sense. And then one more question. Someone was asking, and I'm not sure if this will be for Sandra or for Nikolai, either of you could answer, but they're asking how you assessed cost effectiveness for the program and whether it was looking at healthcare utilization before and after the program, or if there's some other aspect of assessing cost effectiveness.
Nikolai, I think you've probably got more data on that.
Yes, in Denmark, being a universal tax-based system, we have a lot of data on the citizens. So what we do, we have this database and we just cross-reference, and it's not me, it's researchers at the university, completely independent from the clinician. And they actually just look at the health utilization services, the use, how many times at the doctor, at the same time, unemployment fees, all expenses at the service, all these kind of costs will be part of cost effectiveness stuff. And we're trying, actually, we did a 12-month follow-up on the database, and we're doing this 18-month qualitative study. And as we speak, the researchers are trying to do articles about the results and analyze it. But it's fairly easy in Denmark doing these analyses because we know about all the people. It sounds not so good, but we do.
All right. Very good. I think that's all of the questions that have been submitted. So I think we'll go ahead and wrap up. Thank you very much, Sandra and Nikolai, for your time and for your expertise on this topic. It's a very informative and interesting presentation. And
thank you very much.
Well, you're welcome.
For asking us to do it. Yeah.
We're very glad to have you. And just for those of you online, we will be having our next webinar will be on knowing another's pain, reactions of healthcare professionals and others, with Dr. Ken Craig, who's a psychologist, professor of psychology at University of British Columbia. So that'll be on December 2nd. Hope you guys will join us for that. Thank you very much for being online. And again, thank you very much to Nikolai and Sandra for their presentation.
Thanks very much. Bye-bye.
Bye-bye.